We're just going to wait 1 or 2 minutes. I think there's some people upstairs in the oxygen room coming down, so we'll give them a second to come down. Okay, I think that was the people. Okay, great, thank you. Welcome back. Hopefully you managed to get hold of the advice line people or specialist people as you were hoping to. If not, the advice line still remains open on an ongoing basis for any assistance you have. So I'd like to welcome now to get a little bit more detail about one of the treatment areas that Nick Silver started earlier, Dr. Vivek Mehta, who's a consultant in pain medicine at Queen Mary's and clinical network director of pain at St Bart's in London, all of which is extremely useful experience for us. So I will hand over to Vivek and let him take you on a journey through neuromodulation, etc. Okay, thank you.
Is it okay? Yeah. Thank you very much, Dale, and good afternoon. Very, very warm welcome, post-lunch session. There are a few cardinal sins in the public speaking, I've been told. One of them is to speak post-lunch session. Number 2 is to have the same slot before Professor Peter Goadsby. I've got both. So here I am. My name is Vivek Mehta. I'm a pain consultant, and again, we talk about headache, we talk about chronic cluster headache, we talk about the population. So, population of UK? Anybody? 68 million at the last count. How many have got headache? Around 10 million, I've been told. Sort of a diagnosis. Chronic cluster headache, or cluster headache, less than that. Episodic, really, really less. Chronic cluster headache, really, really less. How many headache neurologists have we got? I spoke to one of the headache neurologists about this, and the rough figure was about 34 to 35, something like that, were properly headache neurology trained. Now we talk about the disparity. I come from even far extinct species, and my species is pain medicine. Now how many pain medicine, for God's sake, are interested in headache? One. Not many, not many. And I'll tell you why. Because it is interesting. The headache, when we do pain medicine, as pain physicians, pain doctors, we do not have headache in our curriculum. We talk about musculoskeletal pain, we talk about back pain, we talk about every sort of pain. We hardly talk about headache. We finish our training, very few of us know about cluster headache. We become consultants, and I'm sure you would go to a pain clinic and you would tell about your story, tell about your problem, and the person who's sitting across is literally like white-faced. He has no idea what you're talking, what you're going through. And that is a very, very common phenomenon because there's hardly any training there. So slowly and slowly we have moved on from there. And then the headache came up, and now the curriculum comes up, and the new curriculum is being written, and the new exam for pain has come up. And actually, you'll be very proud to know that headache is a question in every exam that a pain doctor has to go through. So things will change. And that's what we're going to talk about in the next half an hour or so. What I'm going to talk about is something really, really niche, something that I'm really passionate about. And that is called neuromodulation. And Dr. Silver talked about very fantastically this morning about the non-invasive neuromodulation, gamma core, encephaly, and I'll briefly tell you about that, but I won't dwell on it. I'm going to focus really on neuromodulation, which is occipital nerve stimulation. I'll tell you my journey about ONS, how I have grown in the last 10 years, and I'll present some of the data, and I'll leave it for you to decide where it comes to. And then we can make an informed decision as to where this particular therapy should be offered in the armamentarium. It is there, but who should get it, when should get it, how you should get it, what are the criteria? And then we'll come to a common sort of a future plan that we have developed, and I'll propose it to you, and we'll see where we take it from. Does that make sense? Okay, let's make a start then. So, This is something you know. You know about the headache disorders. I won't tell you much about it, but prevalence of 48.9% in general population. We talk about the migraine and cluster headache, 15% and 0.1%, and that's where the 68 million and 10 million came from. And you can look at the 0.1% of 68 million is your cluster headache population. Epidemiology, one of the most debilitating conditions. Hardly any pain doctor knows about it, and that's a shame. Lifetime prevalence, 15 to 20%. 8 million people suffer with migraine. And every day, the migraine attack affects 190,000 people in England, and more importantly, the absentia from work or school. So it's a young population as well. I will not go into it because obviously we've gone through a lot. But basically what we're talking is a disorder of the brain. What we're talking is pain being a component that is reliant on activation and disruption modulation of the trigeminal vascular system, which is sitting nicely in the brain area. So when we talk about neuromodulation, we talk about stimulating that particular area. How do we do it? We can do it from outside, and we can do it from inside as well. And what I want to do is I want to break some myths about neuromodulation. I want to break some barriers about neuromodulation. People understand actually it is not that difficult or not that a big thing that we talk about. So let's make it simplistic now. This is looking at what is happening in the neurophysiology. So if you think about your basic science, how it is working, then lots and lots of key areas in the brainstem, and you can look into those, where actually there is cross connection going on. And also there is a parasympathetic system, which is again responsible for cross connection. So there is some sort of a misnomer or mismatch going on in all these circuits that results in the painful area. I mean, you are all here. You can actually relate with that. So we're talking about lifetime prevalence, increased risk of sleep apnea, anxiety, depression, suicidal ideation, more common in smokers. What happens? There's an activation of parasympathetic system, lacrimation, congestion, rhinorrhea. There's also sympathetic dysfunction, which is meiosis and ptosis. The eyelid, the eyeball can droop, and actually the pupils constrict. So, again, unilateral, more right side than the left side, lacrimation, rhinorrhea, nasal congestion, ptosis, duration between 50 to 180 minutes, frequency 1 every other day to 8 daily, and actually you can have episodic and chronic, where episodic is attacks from 7 days to 1 year with pain-free remission of 3 months. Majority of patients, and I spoke to quite a few today during the lunchtime, have got episodic cluster headache. Chronic cluster headache, attack for 1 year with pain remission less than 3 months, 20% of prevalence, and there were a few chronic cluster headache as well. This is something you can all associate with. Sensitivity to light, sound. A quarter will have nausea, vomiting, restlessness, self-injury, dysautonomia, circadian rhythm, so varies with the heart rate as well. And actually, you know exactly when it's going to happen. You know exactly when it's going to come. So 80% can actually predict the attack between 2 a.m. 3 a.m. and there is an annual rhythmicity in 2/3 of episodic cluster. We went through differential diagnosis this morning, but there is a whole spectrum of syndromes you can look at, differential between hemicrania continua, paroxysmal hemicrania, Sung-Suna, and obviously the secondary headache disorders. So, if you get hand to, this is one of the articles that was published in British Medical Journal last year in April 2022. And actually I took a lot of reading from there, where they talked about the recent advances in diagnosis and management of cluster headache. So we talked about investigations today, and these are the 4 investigations that were written in that particular review article that people with cluster headache should have. So MRI brain with cavernous sinus and pituitary area, a magnetic resonance angiography of head and neck, pituitary lab testing, but also there is association with sleep apnea, so sleep studies. So the 4 investigations that were recommended there. And again, this was all discussed today, so I won't go in detail, but just to have a very snapshot review and snapshot view. The acute treatment, subcutaneous sumatriptan, nasal zolmitriptan, nasal sumatriptan, and oral zolmitriptan. This causes vasoconstriction, and obviously there's an activation of specific receptors that will help. Oxygen, we had some really nice breakout sessions, but also non-invasive vagus nerve stimulation. Steroids have been recommended, occipital nerve blocks, oral tablets, and obviously dihydroergotamine DHE with serotonergic action. Preventative treatment that was recommended in that particular review article was the verapamil, lithium carbonate, melatonin, zucacapsaicin, baclofen, galcanezumab, and neuromodulation. I'm going to focus now on neuromodulation from my non-neurology, chronic pain, neuromodulation background. Something very interesting, I just want to bring it up, was the future, and we talked about the future, and this is something I was Googling into, and I don't know if it will happen or not, but actually they are putting some clinical trials on Botox at the SPG, so sphenoparatine ganglion as well. You actually can inject a bit of Botox there. There's a clinical trial going on. That may or may not happen. So we talked about the vagal nerve stimulation today, and we talked about the gamma core, where actually you're looking at the afferent vagus fibers being stimulated, which actually results in the perception of pain being blocked from the trigeminal nucleus, thalamus, and the cortex. So there's a whole mechanism that is responsible for the gamma core. We talked about the preventative and acute treatment of chronic cluster headache, so PREVA study, which was the looking at the non-invasive gamma core stimulation. We talked about the basically looking at standard of care, where the patient were randomized to receive either the standard of care plus VNS or just standard of care, and actually then the patients went into an open label phase, which was standard of care plus the vagus nerve stimulation. So the 2 weeks, 4 weeks, and then the 4 weeks, and the non-invasive vagal nerve stimulation were twice daily and as needed for rescue. And the primary endpoint for this particular study was reduction in number of cluster headache attacks per week during the last 2 weeks of the randomized phase as compared to the baseline. So that was the comparison, and there was no sham actually. So there was, I think, standard of care plus the device or just the standard of care. And this is the response rate. This was published some time ago now. This is the PREVA trial. We're looking at the frequency of cluster headache per week. So you can see on the group which has got the standard of care plus the VNS, which is on the left-hand side, as compared to the standard of care alone. And you can see this is the baseline here, number of attacks per week, and this is n equal to 37 after the randomized phase, and this is the pre, and this is after the randomized phase. And if you look at the 50% treatment response group, so blue being the non-invasive vagal nerve stimulation as compared to standard of care, so it was a 37% patients have more than 50% treatment response rate. So it was clear-cut that actually if you have a standard of care and you combine this with the non-invasive vagal nerve stimulation, the results are much, much better. This was looking at the acute treatment of cluster headache with the VNS. So the ACT studies, the ACT 1 study and ACT 2 study. So ACT 1 study was 133 patients, 88 of them had episodic cluster headache and 48 had chronic cluster headache, and they were randomized now to non-invasive vagal nerve stimulation versus sham. So the previous one was not a sham, this was a sham controlled trial, and this was a primary endpoint which was pain relief at 15 minutes. And you can see that this is the looking at the percentage changes, all subjects, episodic cluster headache and chronic headache, and you can see actually that non-invasive vagal nerve stimulation is effective for acute treatment of episodic cluster headache, but not chronic cluster headache as per this clinical study. So that was the non-invasive one. Now I'm going to draw you now to the invasive one where my expertise and interest lies. So basically what we are talking now is occipital nerve stimulation. So what is occipital nerve stimulation? What we're talking is a small pacemaker. So think of a pacemaker. Think of somebody who has got a heart problem and has got arrhythmias or heart is not playing well. You go to a cardiologist, they look at your heart, they actually say your heart is not conducting properly. We put a pacemaker that will override your cardiac activity. What it will now do is it will influence the heart, it will override the activity so the heart conducts the signals properly. Once the rhythm of heart is better, the contraction improves. The contraction improves, the cardiac function improves. So that is the theory behind a pacemaker. Now take the same theory of pacemaker to occipital nerve stimulator now. So occipital nerve stimulator is a small device which is this size. It sits in your body through a small operation and has got 2 electrodes which are sitting at the back of the head. So it is done through a small operation which takes about 45 minutes to an hour. Done under general anesthetic, a cut is made at the back of the neck. Through that cut, we have one wire going at the back of the head on the right side and second one on the right hand side. What we are trying to do? We are trying to stimulate the nervous supply C1, C2, C3 that is going inside the brain. So that is basically a peripheral nerve stimulation. That electrodes are then connected to a box and the box is inside. What happens 45 minutes an hour down the line? You're asleep, have the operation done, you wake up. Once you have woken up, it's a normal hospital stay, you go home the same day. It's a day case procedure. After that, you are followed up in 2 weeks' time. 2 weeks down the line, you will see the nurse, you will see the company rep, the programmer, and we give you a stimulation. There are lots of ways how we can stimulate that particular device. So you can actually have a tingling feeling in the back of the head, which is your conventional stimulation. So, for example, patients will have some sort of feeling at the back of the head, which will override your original headache, which will reduce your overall headache. So that was your conventional stimulation. Now with time, we have seen that spinal cord stimulation or dorsal ganglion stimulation or other modalities of stimulation, we don't need to create those paresthesia stimulation. You can actually have paresthesia free, which means you don't even feel anything. What we are talking is a different frequency. So there is a whole physics here. It's Ohm's law. V is equal to I into R. V is voltage, I is your electricity current, R is your resistance. Very simple basic physics phenomenon. And what we are talking is how actually we can modulate these things. So you can change the frequency, you can go high frequency, you can go low frequency. The more higher frequency you go, you will not feel anything, so which is called the paresthesia-free stimulation. Low frequency, which is 40 hertz, is a standard frequency where actually you feel tingling. It's very, very individual response. Some patients that we do like tingling. They like to be in control. They like to know actually something is working for them because they know something is going at the back of the head. And the moment they stop it, it will go. Some people say, I don't like any feeling. They would rather go for a burst stimulation. So lots of ways you can do that. So that is your basic concept of occipital nerve stimulation. Once you have done the procedure, then you have the programming in 2 weeks' time. But then ideally you need to be followed up. And that's where the important thing of a proper MDT setup comes up. So you have a follow-up which is 1 month, 3 months, 6 months, 12 months, 1 year, 2 year, 3 year. Now, if you have spinal cord stimulation, which is looking for your pain in the back and the leg, for example, and you have this pacemaker, the results are like this. You put the device in, it's instantaneously, it blocks the pain, it goes away. Occipital nerve stimulation is slightly different. The results are never straight away. You may have a fantastic response next day. I would say it's more placebo than anything else. What you would really see is slowly and slowly it improves. You need to give it time. Because think about it. This is a very complex chronic phenomenon. What is happening is, from the brain, the nervous system is going towards from the periphery, is going right to the TCC complex. What we need to do is, we need to modulate it slowly. So it takes weeks to months. And normally we actually give 6 months to a year before we say the treatment is effective or not. And after a year, or for example 18 months, if it is still not effective, we take it out. So it is reversible. It's a surgery that can be done, that is reversible. So that's where we are. That is the basic concept of the surgery. Not many centers do it, but those centers do it, they do in bulk. And that's how it should be done. Because if you're doing maybe 4 surgeries a year, then perhaps you should not be doing it. Because it's like the more you do, the better the results are. And that's with any phenomenon. Practice makes a man perfect, that sort of thing. So if you are doing it, you would do more and more of those. And that's something we have seen in the last few years. So that is the concept. So now we're talking about how does it work. So what I spoke to you about was what are the mechanics of it, what are the nuts and bolts of it as a surgical thing. Now let's go back to how does it work. So the mechanism of action is the original concept of gate controller theory, which means actually you are activating the A beta fibers which are blocking the painful response at the segmental level. So think about your original 40 Hertz conventional frequency, which means you are stimulating something, you can feel something, and that feeling actually is responsible for the pain control. Then you have the involvement of supraspinal structures. So a lot of things is happening inside the brain. For example, the trigeminocephalic nucleus. That is responsible for it. And then you have a neuroplasticity, which means we really don't know what's going to happen. So lots and lots of ways actually the way the neuromodulation works. So when we talk about the specific response in cluster headache and SUNG, I mean, we know, and we've got some trials that I'm going to briefly talk about. If it's a chronic migraine, the results are very, very poor. They're not great. But actually, one disorder, one disease, where actually the results are good, are the autonomic symptoms, which is the TSEs, the cluster headache, the SUNG suna, the hemicrania continua, and the paroxysmal hemicrania. So this is a sort of a published data that was looking at number of implants, and you can see the cluster headache had the majority of them, with 50% improvement in frequency and or severity by Professor Goldsby actually. What are the predictors? How do you select these patients? And that is the key question. Now, occipital nerve stimulation is funded through National Health. It is commissioned, it is one of the very few therapies that is commissioned by the NHS England. Now, NHS England have got a very strict criteria as to who can be eligible for this particular therapy. But also it is important for us as physicians to be able to offer to the right people. Because if you look at the cost, it actually is about 25 to 30,000 pounds when we talk about the total cost. Because that's exactly what the cost of device, the leads, the follow-up and everything, the surgery time, the anesthetic time, the pre-op time takes it. So there is a process for that. And this process is really important because I'm very proud of something that we set up in parts of Dr. Barr actually many, many years ago. And this is the headache MDT we talk about. We talk about headache MDT actually where we have a mechanism where we will screen these particular group of patients like yourself. So the patients are diagnosed, they have a phenotype, they have a diagnosis of chronic cluster headache, they have a diagnosis of cluster headache, and they have tried X, Y, and Z in terms of treatment options. But then they are assessed from a psychology point of view. Because actually, as somebody who wants to implant, you want to implant everybody. If you have got a hammer, everything is like a nail. You want to bang, 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 bang. So what you need to do is you need to have some sort of a rationale. You need to have some sort of a balanced approach. And that balanced approach comes from an MDT, where actually you have a psychologist, you have a neurologist, you have a neurosurgeon. We all sit in one group, and then we evaluate the situation. We evaluate the patient. We evaluate actually how much is this patient going to engage with the therapy. Because If the patient is not going to engage with therapy, I can be 100% sure this will not work. It's a question of how much engagement comes, how much of understanding comes, how much of commitment comes. And then what we look at is how much is anxiety and depression. Because we know that anxiety and depression are key parts of headache, we know that, but also if there's an increased anxiety and depression, the results are pretty poor. So there has to be a balance there. There has to be something that we do in terms of managing your expectations, managing anxiety, managing depression before we go ahead. Then you can also look at what is the evidence of medication overuse. So again, we know that if you are overusing medication, you're taking lots and lots of medication, the chance of it working are pretty slim as well. So all these things are really important when we look at these things. Now, there are lots of studies that have been published, but I really want to draw attention to one clinical trial, actually, that was published only last year. This trial was done in Netherlands. It was the first sham-controlled trial. Sorry, not sham-controlled trial. This was the first randomized controlled trial where differential frequency was done. And this particular was done in Netherlands, which actually led to changes in the regulations in Europe, how NHS, how their local commissioning is happening. So this was a multi-center, prospective, double-blind, electrical dose control study. So it's not a sham control trial, my apologies, but electrical dose control studies where 131 patients with chronic cluster headache who had failed more than 3 preventative treatments were randomized to 24 weeks. Now that's important. We talk about long-term effect here, long-term randomization. So 24 weeks of occipital nerve stimulation in 1:1 ratio. So the stimulation was either 100%, you give 100% stimulation, or you give 30% of the individually range between paresthesia threshold and near discomfort. So the two groups were high versus low intensity ONS. One had a very high intensity, so really could feel it, and the other one was low intensity. And all patients received optimized stimulation in weeks 24 to 48. The primary outcome was the mean weekly frequency in weeks 21 to 24 as compared to baseline. So you have on the other side now 100% stimulation, and this is week 21 and week 45, and 30% stimulation week 21 and 45. So the study design was 1:1 random allocation, high versus low intensity occipital nerve stimulation. So the patients had baseline, then they were randomized, and then they were randomized to the two groups, and then they had an open label where 100% of maximal stimulation was done. There was a 12 weeks baseline observation, 10-day run-in period with 10% stimulation, so adequate washout, 24 weeks double-blind period with stepwise increase of stimulation, and 24 weeks of open label optimal treatment. The results were, this is the outcome of total study population, n equal to 130 patients, so one of the biggest studies that's been done. More than 50% responders at week 21 to 24, 44.6%. More than 30% responders, and that's what we consider as an impact guidance, 55.4%. So that was the results when we talk about the percentage in terms of primary endpoint. But I think when we talk about ONS, and something yes, we talk about the results, we talk about the data, we talk about the evidence, I agree there. But I think when I talk about neuromodulation, I talk about the patient in the whole perspective. A lot of things. And we talk about the reduction in headache, we talk about reduction in the medication, but we also talk about mental well-being, how well they feel, how good they feel. And something that we have done with neuromodulation consistently, and that's the same concept of spinal cord stimulation for back and leg pain. So I do spinal cord stimulation, I do about 200 implants a year. That's what I do. The patients that I'm operating on, when I educate them, I'm very clear. I say, this is the device that we're offering. Now, what is your goal? Is your goal to run a marathon? Is your goal to reduce your medication? Is your goal to be pain-free? If your answer is pain-free, you will probably never be able to succeed the goal. What we are talking is managing expectations and managing symptoms, but also reducing medications, reducing anxiety, reducing depression. And majority of patients that I do for spinal cord stimulation, not for headache, I'm talking about SCS now for a second, actually have got a better pain relief. But what they really do very well in is coming off their opioids, coming off their medication. Majority of them actually are off opioids, and that's our aim. They are mentally well-being, they are able to participate, they are able to be active socially. And that's what we talk about, managing pain and managing expectations. So let's take the same example for cluster headache now. And this particular group, you can see the mental health sum score and the physical health sum score, there was a significant improvement from baseline at 6 months and 12 months. We talk about patient satisfaction. So week 24 to 99 out of 109. So 90% of patients, and that's where it comes to, because it's expectation. 90% of patients would strongly recommend ONS. At week 48, almost a year now, 93 out of 96, which is 96.8% patients will strongly recommend ONS stimulation. So these are the patient feelings we're talking. We're talking the feedback from the patient, which I think is really important. We can all sit in our little cocoon and we talk about numbers. But actually when we come to it, we can talk about what is the patient feeling. What do you feel? How do you perceive your pain? What is it for you? And that's where the treatment comes up when I look into it. I said about it, ONS does not work straight away. It does not, if you're looking at 12 months data, yes, you will have a response. You really need to look at the long-term data. Again, very simple concept, and you can look into something really new that has come up over the last 6 years, is multifitter stimulation. Now, this is for completely back pain. You're stimulating the nerve supply of the back muscles. And we have seen that when we start about restorative thing, from baseline to 5 years, results are like this. It's not like spinal cord stimulation, but the results go like this. With any neurorehabilitative rehabilitation, it takes time. So with ICON study, the 3-year data is 55% were responders at more than 50%, and 84% at 3 years recommended ONS. At 5 years, out of 31 patients followed up so far, 90% recommended ONS, and 71% were responders, which means more than 50% response. So discussion was, 50% of patients have 50% reduction within 4 weeks initially, and then a stable baseline period of 12 weeks. So what is the evidence of neuromodulation in headaches? And I'll focus mainly on the invasive one here, the ONS one. There is evidence in terms of preventative and for cluster headache as well, but it's not a sham controlled trial. So if you ask me, is it sham controlled? The answer is no. It's not a level 1 evidence, but that's what we have got. It's really difficult to do a clinical trial in this particular group of patients. So what is the criteria? How would you select this group of patients? So if I have a cluster headache, is this something that you offer straight away? The answer is no. You have to go through a proper systematic process. And this includes a definitive diagnosis of primary headache syndrome. As we said, this patient has to be diagnosed properly, has to be highly disabled, and with chronic cluster headache, the patients are. We know that. Medically intractable, which means failed trials, and failed non-invasive neuromodulation as well, because this is a 30,000 pound device. It is an operation. It is a small operation, but it is an operation. So if you can try some simple things first, that's what we should do. And then you have the peripheral nerve stimulation, which is the cluster for ONS. And it's a shame that we had a phenopalatal ganglion stimulation years ago that the company went bust, but worked really well. We did the most in the country for that. It's really good. So that was the neuromodulation. Now this is little our journey that we have done. So this is about the Barth's headache MDT, which is now 10 years. And I'll tell you a brief story about it, how it evolved, and what is the future plan, how do we see, and how do we want to interact with a group of patients, but also with the key opinion leaders across the country. So this is it all started. 2012, when the NICE recommended the PREEM trial, the Botox, that's where on one boozy evening in US, I got interested into headache. As I said, there was no training, you see. You learn from your peers. You speak to people, you get on with people, and that's how you learn. That's how I learned of a trade going to US and with different parts of the world. So I went and learned from American Brain Society, did some workshops there, 2012. And 2013, we had the first headache MDT. We started with Dr. Bara, myself, and our psychologist. And then we had the first implant in 2013, and we have done few implants, as we say, every year now. And that's what we're doing. We had the 2018, we had the commissioning of spinal pattern ganglion, but today as we stand, we have an NHS England commissioned service at Barts Health, where we offer neuromodulation, but more importantly, we're part of National Neuromodulation Registry, which means each patient that has a device has to be followed up. All the data is entered into a national register, so 4 years down the line, if you want to find out what's going on, you should be able to. You should be able to actually look at your outcomes. And from a surgeon point of view, you should be able to see what you have done, how you have selected patients, and what is the outcome. So that is all part of the service. So this is our strategic vision at Barts, which we have been doing. And as I said, this is an NHS England Commission policy where you have to have specific criteria that you meet before we go ahead and do it. But this is something we have done over the last few years, and evaluating responses. We want to be able to help patients, and we want to create a referral pathway. That's part of this talk, is to create a referral pathway where actually we are able to select and identify the appropriate patients who will benefit from it. So if you feel, from a patient point of view, you need to go to your GP, you need to go to a headache neurologist, and from that headache neurologist, you need to get referred to one of the centers. As I said, Barts, we are very happy to look after, but your regional centers will be able to do it. There are few centers who do in the country. And I'm very happy to have a chat after this talk if you want me to talk to you about your specific local center, and I can advise how it works over there. But that is the future. I've spoken to Nick about this, Dr. Silver, just a bit ago. If you ask me one thing I'm passionate about creating a strategic alliance. I'm passionate about creating an academic strategic alliance where actually we will have a national MDT once in 2 months or once in 3 months, we can talk about it, where we will be able to discuss a patient who has specific problems with a specific key opinion leaders across the country. I mean, a lot of bad things happened with the pandemic, but one good thing happened. And the good thing was we realized actually that we don't need to be physically present to see or discuss something. The whole virtual world around us started. And I was speaking, and this idea, it's not my idea, I took it from a hematology oncology team actually at Great Ormond Street. And they do exactly the same. They have complex patients. And actually they are able to discuss those particular patients with anybody in the country. So anybody in the country, if you have a patient, you go to your doctor, and this doctor will be able to put your name forward to this particular alliance that we're talking, and that particular patient can be discussed with all the conventional GDPR and everything, and be given an opinion how to go with the next steps by a key opinion leader across the country. And that is something I'm passionate about, and I'm hoping that maybe 2 or 3 years down the line, I'll be back again and present you the data of what we have done with this one. So something, watch the space. So that's it. That was my journey of headache so far. I hope you liked it. I'm open for questions.